Welcome to Westmead Private Hospital's virtual GP education program. Today we are joined by Dr. Peter Wu, respiratory physician, and Dr. Graham Meredith, cardiothoracic surgeon. Today, Peter and Graham will be discussing nodules in the lungs, looking at presentation, investigations, treatment, and resection guidelines.
So thank you for inviting me to do the talk. I see quite a few people online that I recognise the name of. So look, I was asked to give a talk about pulmonary nodules, and it is in fact a very vexing topic. And it's one of those topics that has become very commonplace in general practice and actually makes up a fair percentage of the respiratory referral and work. So the idea of this talk is not to make you become an expert, but for you to understand a little bit more about pulmonary nodules, what they could be, and how do you deal with them, and how do you refer them off in a very prompt manner. I think the important thing to understand with this topic is basically, whilst the thing that makes everyone anxious about pulmonary nodules is this a lung cancer? And I think that's probably or is this a cancer? And this is a question that's in everyone's mind, but a large number of these are not cancers, and we need to have some sort of algorithm for us to sort out those benign and non-malignant lesions and to manage them and the patient expectation appropriately, as well as being able to identify the high-risk nodules and refer them appropriately for further management. I'll leave the surgical aspect with Dr. Meredith's expertise. I don't think I've ever resected anything in the lung, so I'll leave him to tell you all about that. So I think in a talk like this, it's always good to start with some statistics. Regarding the statistics of lung cancer in Australia, in 2020, the estimated number of new cases is about 13,000. And more in males than females, and it's expected to be about 9% of new lung cancer. So 1 in 10 lung cancers new cancers you're seeing will probably be a lung cancer. And yet, despite being only about 9% of the patients, about double that amount is actually double that amount in deaths from cancer is actually due to lung cancer. So in terms of death, it's disproportionately represented. And that probably does suggest to us that often the disease is being diagnosed too late to allow curative treatment. And secondly, our treatment may not be quite, there's not a good enough program to identify early lung cancers. And thirdly, I think perhaps some of the treatments may not have, there may not be as many treatment arms for advanced lung cancers, although this seems to be changing in the last few years. So let's start with a few definitions of pulmonary nodules. Regarding pulmonary nodules, this is just a name. Basically, a pulmonary nodule is something in the lung that's less than 3 centimeters, and by convention, something more than 3 centimeters is called a mass. Whether there's any clinical difference there probably isn't really. It's just the size that's a cutoff. Now, if you look at the incidence of pulmonary nodules, it's actually very frequent, about 0.2% x-rays that I've done, and about 50% of all lung CT scans. So this is a very, very common clinical problem. The problem is the lesion can be benign or malignant. And if you look at the statistics, about 90% of pulmonary nodules less than 2 centimeters in diameter are benign. So most of what you're seeing under 2 centimeters is benign, and there's a large number of these. And the question is, how do you pick out those 10% that are or could become cancers? So just to give you some data, I think I always find this a very interesting study. So this is a landmark paper published in New England Journal in 2013 by Annette McWilliam and from Canada. They did lung cancer screening data and examined over long-term follow-up on what prospect there will be, what difference lung cancer screening high-risk patient could make. So basically, they took a group of high-risk patients for lung cancer, so current or former smokers, between age of 50 to 75, without a previous history of lung cancer. And in essence, they estimated with our previous population algorithms of and cancer risk stratification algorithms of these patients being more likely to have a more than 2% chance per year of having a lung cancer. And they then, so 3 years risk of lung cancer more than 2%, not the year. and then they did yearly low-dose CT scans. And what they found is that there was a ton of pulmonary nodules. In fact, when you take once they had two sets of data, in one set of data there was about 74% of patients had pulmonary nodules, and the other cohort, probably 1 in 5, had a high percentage that had pulmonary nodules. And the issue is not all of them are malignant. So even a high-risk group, the cancer rate from the PanCan data was only about 5.5%, and the cancer rate from the other data is about 3.7%. So to make that more absorbable information for you, so even when you take a group of high-risk patients for lung cancer, when you do a CT every year, 3/4 of them will have a pulmonary nodule, but only about 1.5% of nodule that you detect are malignant, with an overall cancer rate of 5%. So the thing to keep in mind is the large number of the pulmonary nodules that you'll be seeing are probably benign and probably not malignant. What increased the risk of cancer? In this study, they found older age, female sex, family history of lung cancer, history of emphysema, the largest the nodules are, the nodules being upper lobe location, being a part solid nodule, and we'll come back to this topic of part solid versus solid nodule. A lower nodule count and speculation of nodule are all increases the risk of being a lung cancer. So the next question to ask is, well, if these large number of these nodules are non-malignant, what are they caused by? In fact, there are many causes for pulmonary nodules. So it can be from infection, so TB, atypical mycobacterial infection, also all sorts of fungal infection. Although in Australia, in reality, the rates of fungal infection are probably lower. In terms of the histoplasmosis and Clostridium mycosis, these are much more prominent in North America and certain other areas around the world. But in Australia, the rates of fungal infections are probably fairly low. There are other non-infectious causes, from just inflammatory to conditions like sarcoidosis, ANCA-positive vasculitis, granulomatous polyangiitis, rheumatoid nodules. So there are a large number of inflammatory causes of nodules. Regarding to cancers, there are benign tumors, so neoplasms are benign ones, so a large range of benign tumors, as well as malignant tumor, including primary cancers in the lung, lymphoma, carcinoid tumor, sarcoma, and metastatic tumor. So there are a large number of these tumors around, these lesions around. In terms of symptoms, they're usually found asymptomatic when you've done a CT for one reason or the other, or in a lung cancer program if you're overseas. If symptomatic, they may have a cough, particularly if the lesion is involved in the airways. If they cough up blood, they could cough up blood if it's involved in the airway. Chest pain if it's involved in the chest wall. And sometimes the cancer will have systemic symptoms, and also weight loss and anorexia. So I just wanted to introduce a new concept here of solid or versus subsolid nodules. And this may or may not be a concept that you're familiar with. So in the nodule, in terms of nodule, we now understand there are solid and subsolid nodules, and they tend to behave different clinically. And whilst they both can have cancer malignancy potential, their behavior is probably a little bit different. The definition of solid nodule is pretty simple. It's something between 0.3 to 3 centimeters. And basically, when you look at the CT scan, you can't actually see through it, and it obscures the bronchial and vascular margins, so you can't actually see anything through the nodule. The subsolid nodule are nodule that you can see through, and so you might be able to see some underlying structures. And sometimes it's grayish and hazy, and it's also called ground glass nodule. The important thing to note is that whether you call a solid, subsolid, and diameter, so there's a significant inter and observer variability in the classification. So this is a Northern America cancer guidelines on how to manage pulmonary nodules. While it looks very complicated, it's actually fairly simple. Basically, you find a pulmonary nodule, and the question then is, what is the risk of this being a lung cancer? So you do patient assessment of the risk factors, which is outlined there, and then you look at radiological factors, some of which we'll discuss and we'll come back to. And then if you're uncertain and you may be in a moderate probability group, you may further perform a PET scan, and that might help to further risk stratify. And the important aspect here that I like to outline is the multidisciplinary nature of this disease. And it's important now in this modern day and time to involve a multidisciplinary team who experience of lung cancer in terms of evaluating the risk as well as approaching the diagnostics and therapeutics. The other thing that you can do is, I think every patient you see with a pulmonary nodule, it is an opportunity, if they're a smoker, to intervene with smoking cessation. Even if they have stage 4 cancer, smoking cessation is still beneficial and associated with improved outcomes. So in terms of the general lifestyle factors, I just want to quickly run through them. There are a number of lifestyle factors that you probably already know about. So smoking is probably by and large the most important one. The earlier in life you smoke, the more you smoke, the longer you smoke, or associated with an increased risk of lung cancer. People often ask me, does marijuana increase the risk of smoking, cancer? Am I better off smoking marijuana than cigarette smoke? In this area, it's still a bit debatable regarding to the risks. There may be some increased risk in marijuana smoking as well. Then there are other environmental occupational risk factors. I think secondhand exposure, passive smoking now has been established, but there are other well-established exposure risks that we know about, such as asbestos exposure. Actually, does not only increase the risk of malignant mesothelioma, but actually also increase the risk of lung cancer. Uranium exposure, diesel fuel exposure, silicosis is on the rise due to the use of Caesar stone and other marbles for kitchens and other materials. So we may be seeing a rise in silicosis-associated lung cancer and all sorts of other inhaled chemicals. Air pollution has been proposed, and arsenic in drinking water has been seen in cohorts as well. In terms of the personal risk factors, unfortunately, the older your patient is, the more likely they are to have lung cancer. A family history of lung cancer is actually very important, and this is probably even stronger in the non-smoker group. And I think I would also always take a family history of lung cancer quite seriously. As we well know, established diagnosis of COPD or pulmonary fibrosis also independently increase the risk factor for lung cancer. And a personal history of other cancers such as lung cancer, head and neck cancer, and bladder cancer, all actually increase the risk of nodule being a lung cancer. Previous radiotherapy to chest for other cancers is also another risk factor. So talking about moving on to radiological factors, basically the message here is the bigger your size of nodule is, the higher the risk it is of being a lung cancer. I get a number of referrals for 2-3 millimeter nodules. As you can see, nodules less than 4 millimeters has a very low risk of being a lung cancer. Even nodules of 4 to 7 millimeters, the risk of lung cancer is fairly low at 1%. And in general, I think 8 millimeters and above, we start becoming more concerned and more serious about these. And I think, at 8 to 20 millimeters, it's about a 15% risk. And when you get to more than 20 millimeters, the risk rises to 75%. So if you've got a nodule of more than 2 centimeters, 3 out of 4 times, this is going to be a lung cancer. Growth, in terms of if the lesion is stable over 2 years, it's associated with being benign, and hence you'll see a lot of guidelines use a 2-year mark. This is a trap as well, because some cancers grow very slowly. So just because a nodule is stable for 2 years does not imply it's definitely malignant, and we still have to use discretion and judgment. Calcification is more likely to be associated with benign, although carcinoid tumors and other osteosarcoma and chondrosarcomas can also contain calcification. The shape, being polygonal shape, was a sign of being benign, and the 3D ratio being more than 1.7 was also a sign of benign. In other words, if the shape is, the cancers all expand out, they grow in 3 dimensions, they don't grow in 1 dimension or 2 dimension. So if it's looking a bit flat or linear, it's probably less likely to be a lung cancer, is what that says. A peripheral subpleural location is probably more benign, in likelihood benign, and that's probably because there's a lot of subpleural lymph nodes there, and often they come up as nodules. In terms of other signs, margins, so if there's a corona radiata sign, which is a bit like spiculations, it just is multiple spicules coming up for the cancer with tethering to the pleura, this is a sign of malignancy. Being a lobulated scallop margin as an intermediate probability, while smooth margin is more likely benign, but unfortunately, metastatic nodule also look smooth. Air bronchogranuloma is also more common in malignant nodules. So in terms of other radiological features, the solid and ground, what we spoke about so far, solid versus ground glass or part solid components, nodules. In fact, most solid nodules are not malignant. So if you have non-solid lesion, so if you have a solid lesion, malignancy rate is about 7%. But if you get a ground glass nodule, the malignancy rate is 18%. And if you get a part solid nodule with ground glass component or these subsolid nodules, the malignancy rate is 63%. And I guess this is just statistical, namely that I think there are just many more causes of benign solid lesion than there are of benign subsolid lesions. And hence, if you see a subsolid lesion, they're actually more often than not malignant. The other factor, contrast enhancement, less than 15 enhancement, also has a high predictive factor of being benign. However, this is only applying to nodules that are spherical and homogeneous with no necrosis in the middle, no phattocalcification. So if you see a very smooth, even nodule, and you measure Hounsfield unit, this is a good sign, but this is not designed for a large nodule which has necrosis in the middle and picking a section of it. So we talked about PET in terms of modulating the probability of cancer. Now, if PET has avidity, it may increase the likelihood of this being a cancer or a cancer that is growing. It has a high sensitivity of 95%, but unfortunately, the specificity of PET is not good at 80% only. And particularly if you've got a large population of granulomatous disease, so high TB, or in Northern America where they've got high rates of histoplasmosis, actually the PET false positive rate of PET becomes quite high. And in fact, I'm seeing a lot of positivity in PET from what's called anthracosis or dust deposit in the lymph nodes as well. And I see this a lot in subcontinental populations. So there are a number of false positivity. And for PET is unfortunately can be false negative, particularly if it's less than 8 millimeters. So you usually define about 7 or 8 millimeters as a limit of ability for PET to detect, to be used meaningfully. But unfortunately, those are the most difficult ones to biopsy, and hence often it is actually probably advisable for nodules of those size to follow up and follow for any growth. In terms of ground glass nodule, the literature is fairly clear. Even if they're cancers, the PET are often very non-avid, and because of slow nature of growth of these lesions, and hence the ground glass nodules, in ground glass nodules, PET is actually not a very sensitive tool at all. So overall, PET has a role, but it needs to be used with discretion, and also needs to be interpreted with discretion. So just because you're PET positive doesn't mean it's cancer. Just because you're PET negative doesn't mean it's not a cancer. So I just want to quickly move on to the management of pulmonary nodules. So there are, in essence, 3 options here. One is to observe, and I guess this is an option that is most useful for low-risk pulmonary nodules or nodules that are difficult to biopsy or you're uncertain about. Otherwise, you gain a tissue diagnosis, either bronchoscopically or by CT, or alternatively, you send it to a surgeon such as Dr. Meredith, and he can just chop it out for you. And I guess this is probably a suitable solution for nodules that are a high risk of lung cancer, but also a high risk of biopsy, where biopsying to establish a diagnosis may cause more harm than benefit. And it's probably only suitable for early stage nodules that have been appropriately worked up. So talking about the first aspect, the management of solid pulmonary nodules. So this is the Fleischer Society guideline for management of solid pulmonary nodules. And as you can see, this is a pretty busy slide. And the idea here is not for you to learn this off by heart. You can actually look this up online from the Fleischer Society. I actually keep it on my desk because I can't even remember it all. But the important thing to know in this guideline is that when nodules in a low-risk patient are less than, so if you get nodules less than 6 millimeter in a low-risk patient for lung cancer, the recommendation now is actually not to do routine follow-up, given that it is at low risk of malignancy. And even in high-risk patients, it's only recommended to have an optional CT at 12 months. However, as when you get to the 6 to 8 millimeter, where there's about a 1% risk of lung cancer, then sequential monitoring is probably better in this category because PET and biopsy may be difficult. Once you get to this greater than 8 millimeter size, as the risk of lung cancer increases, I think then establish a tissue diagnosis will be important. And if the PET, if it's not easy to sample and biopsy, a PET may modulate the risk. Or if you're not sure whether it's safe to biopsy, short-term follow-up with CT scan is advised. Now, multiple nodules is also followed in the same way, and you use a dominant nodule to guide you on how you so the biggest nodule, the dominant nodule, is the one that you should use to follow the guidelines by. The thing to keep in mind is this guideline is actually only intended for incidentally discovered pulmonary nodules or people more than 35, and the people who had nodules identified in the screening program actually doesn't qualify for this. And they should be approached a different way. Fortunately or unfortunately, in Australia, we don't have a government subsidized screening program as of yet, but there are trials being run at the moment. I understand one's being run through St. Vincent's Hospital. It's not intended for use for people who's already got lung cancer and you're following a nodule in someone who's already got lung cancer because there's a high risk of metastatic disease. And this is also not intended to use for patients who are immunocompromised, as they may be at risk of infection. So some tissue sampling may be more important in that context to exclude infection. The other thing to keep in mind is that the scan should be done at 1 millimeter slices. And I use a lot of different radiology companies around the place. And some of them, they usually do scan at 1 millimeter, but often the slices drop out to save room on their system, so saving the data, and so that you end up getting 3 or 5 millimeter slices. If you think about it, if you're only getting one slice every 5 millimeters, it's really not adequate to assess nodules that are between 6 to 8 millimeters or 8 millimeters. You only get 1 or 2 slices to look at it. So it's important to do a 1 millimeter, and you should be inquiring with your local radiological practice what protocols they're using. And the other thing to keep in mind is the threshold for the recommendation for follow-up is based on the estimated cancer risk of the nodule being 1% or greater. So in other words, if your patient, you follow these guidelines, it means that their risk of lung cancer is less than 1% from that nodule being lung cancer less than 1%, but it is not 0%. And so if the clinical picture is not correct, we should still be doing ongoing further follow-up or refer to specialists for further specialist assessment. So monitoring a subsolid nodule is quite a complex topic. So we now know these nodules because we're doing more CT scan, we're seeing more of these nodules, and these nodules actually behave very differently from the solid nodules, and hence the actual recommendation is actually now very different. The important thing, this is a very busy slide again, but the important thing is that most ground glass nodule or less than 5 or 6 millimeters probably are benign and probably represent atypical adenomatous hyperplasia in the lung, and probably doesn't need to be followed up, although we don't clearly understand from the data that we have whether there's a direct relationship to atypical adenomatous hyperplasia to development of lung cancer in the future. So in other words, we're uncertain whether this could be a precancerous lesion, and the data is not clear on this. The other thing to understand is these lesions have a very, very slow growth rate. So the first CT that is generally recommended is to be done at 3 millimeters, so at 3 months. The reason to do it at 3 months is a portion of these lesions disappear, and in fact, these GGOs or ground glass nodules are benign, and about 20%, a lot of benign in 20% of the cases. So if you do a CT scan at 3 months, about 1 in 5 of these nodules disappear and no further action is required. And hence that's a recommendation why in general, you then do a CT scan at 3 months in the first instance. Now, the the other reason to do this is because these nodules grow very slowly, and they actually, on average, grow over 2 to 3 year time frame. So doing it at 3 months will not so you won't miss the opportunity to cure or curatively resect or treat a lung cancer by waiting for 3 months. So really, if you're doing a scan at 3 months, you're waiting for the nodule to, so you're seeing where the nodule disappear. You're not expecting it to get any bigger. In a small portion, we get a more aggressive form of mucinous carcinoma. You do want, at 3 months, you can capture whether it's in growth, and if there is change, that you would biopsy then. So the message here is a first, in the general recommendation is do a progress scan at 3 months. If it's persistent, then you act on it. The other thing, once more, to emphasize is these scans have to be done in 1 millimeters. And if there wasn't done initially in 1 millimeter, a 3 month scan is an opportunity to do this at 1 millimeter. At that stage.
Before you go on, just a question. Please comment on immunotherapy in lung cancer management.
So look, I don't think I can cover that topic in this talk. That's an independent talk of its own accord, and I just don't have the time to cover this topic at all in the talk. But I'm happy to talk to whoever's online that asks a question afterwards. But that's a separate topic. That's about treatment of lung cancer.
And then just another one that's coming. Does MRI have a role in diagnostic in subsolid nodules?
No, so MRI is actually the enemy of the lung. So in other words, this is a common question I get from patients. I don't want so many CT scans. Can I do an MRI? So MRI is good for soft tissues containing fluids of brain. Soft tissue is ideal for MRI. Lung, unfortunately, with the air, is a very bad interface for MRI. So in fact, CT is the best tool for assessing nodules in both solid or subsolid.
Thanks.
Okay. So regarding the nodules, the first thing is to do a scan at 3 months. And then at that stage, you then decide what to do with the scan, with the lesion. In essence, you either keep observing it with a scan at a longer interval, either a year or sometimes 2 years, depending on what guidelines you read. Or if you think there's a risk, the high risk of lung cancer, you may biopsy it, or you may get a resect it without a tissue diagnosis. The PET scan is of limited use in the subsolid nodule and can often be misleading, and hence is actually not always recommended. And thirdly, how do you understand which ones are more likely to be lung cancers? So as a rule of thumb, if a nodule is more than a ground glass nodule is more than 10 millimeters, there's probably about an 80% chance it's a lung cancer, and the risk of lung cancer increases with the size, and increase if there's a solid component there for more than 5 millimeters. So from my point of view, if you had a lesion that's like 25 millimeters solid component in the middle, I think it should be treated as a lung cancer, and I probably wouldn't wait for 3 months. But these guidelines are really developed for these fairly smallish nodules.
Just another question here, Peter. Are there any guidelines to do chest X-ray, CT chest in chronic smoker to find early diagnosis of lung cancer?
So as I alluded to at the beginning, there are lots of studies now looking at lung cancer screening. Chest X-ray has been overwhelmingly disappointing. So yearly chest X-ray to screen for lung cancer doesn't work. Namely because you often want to get them, for a screening program to be successful, you want to find the cancers at a curative stage. And by the time detecting on X-ray, is probably often they're not curable. So it doesn't really make a difference in terms of downstaging and hence curative treatment. But there are plenty of data in the North American cohorts that's actually shown that yearly low-dose CT scan does result in a reduction in mortality in high-risk patients, and hence it's actually become the part of the guidelines of the North American Society for Lung Cancer Screening. However, this data has not been validated on the Australian population, and hence has not been recommended by the Australian government, but the TSANZ, the Thoracic Society, I think is lobbying the government to make this a recommendation. but I think there are current trials undergoing at St Vincent's and other centres around Australia trying to collect local data to demonstrate mortality benefit. But unfortunately, these trials will need to run it for at least 3 to 5 years to demonstrate these benefits. So I just want to move on from the ground glass nodule. So other diagnostics, so if you're going to biopsy and get tissue, sputum cytology is acceptable. It is. It's a sensitivity rate of 66%, which is actually a lot higher than I thought. However, in the modern day of lung cancer medicine, while it's enough to establish diagnosis, it's probably not enough tissue to do all the other types of analysis that we require, such as molecular testing. So I think in general, the sputum cytology has become out of fashion. There are limited use of ultrasounds, fluoroscopy, and MRI, as we've discussed. And hence CT-guided biopsy and bronchoscopy are the two main tools. CT-guided biopsy has a high diagnostic rate, but once they become less than 2 centimeters, the diagnostic rate reduces. This is also very operator dependent, so it's dependent on the skill of the operator. The major problem with CT-guided biopsy is there is a risk, and there is actually a mortality rate of up to 0.5%, usually from bleeding or air embolism or bleeding into the pleura from the biopsy. One of the major morbidity is actually pneumothorax, and depending on how skilled your operator are, up to 3 to 15% of patients that have biopsy may require a chest drain from pneumothorax, and this then becomes an unattractive option for patients with underlying lung disease. And most of these patients, being smokers, often do have underlying lung disease that would not tolerate pneumothorax. There's increased risk if they're close to the center of the lung and if they have to cross multiple pleural surface biopsy. There are other rare complications that I won't go into that you can read there. Now, bronchoscopy is standard white light bronchoscopy useful with their endobronchial lesion present, but the diagnostic rate drops off as it gets smaller and if there's no endobronchial component. So the bronchoscopy on its own has a very limited utility, as well. However, in the about 10 or 15 years ago, a new procedure and a new camera came in called the endobronchial ultrasound. There are two types of endobronchial ultrasound. This is a linear endobronchial ultrasound, where you can see there's an ultrasound at the end of the camera. The needle then comes out through the sheet, through a working channel, and hence you can biopsy the lesion under real-life ultrasound guidance within the airways. This is useful for cancer lymph nodes and also cancer adjacent to major airways. The other technology that's been around for about 10, 15 years also is what's called a radial probe. And this is where you put a normal bronchoscope in, and then you put the ultrasound through the airways and going to the airway that you think is most likely leading into cancer. The ultrasound will help to find the cancer, and then you leave a plastic sheath in there that marks the position, remove the ultrasound, and put instruments down for sampling. And this is just to demonstrate to you how the linear EBUS TBNA works. So you get real live ultrasound guidance. You can see the needle going straight into the lesion and do the biopsy under real life guidance. And as I alluded to, the most useful part of this is for staging. So the EBUS can actually access all these lymph nodes around the chest. And so it's actually one of the best tools now for mediastinal staging. It's a very sensitive tool, and in fact, the diagnostic rates is about 90 to 92% for cancer lymph nodes, and for parenchymal lesion, probably approaching 90% as well. The radial EBUS, as I spoke about, so you put, as I see, pass an ultrasound. When you get lung, because air is an enemy of ultrasound, you'll get all these hazing and artifact. But once you get a cancer adjacent to airway, you can see it. Then you leave the plastic sheath in there and take the ultrasound out and put instruments into biopsy. The diagnostic sensitivity rate, unfortunately, is a bit lower. It's at about 70%. And the reason is it's only easy to find it if it's more than 2 centimeters. And if the airway leads into a lesion, increase the probability of the sampling. But if it's actually around or not within the airway, then unfortunately the diagnostic rates then drop off. The major advantage of using this technique, as you can see in someone with COPD, in a study done in Brisbane, is that the rates of pneumothorax are very low in comparison to CT-guided biopsy. And this is a major teaching hospital as well. So it's a much safer tool for someone with underlying lung disease if we select the patient appropriately. So in summary, I just want to wind up there because my time's just about up, and then I'll pass to Dr. Meredith. I think the message I want to leave you with today is that you'll see a large number of pulmonary nodules in your clinical practice, and just keep in mind, most of them are benign and have a wide range of number of causes. It's important that you risk stratify the pulmonary nodule, meaning that how likely are these to be a lung cancer based on clinical, radiological features, and also you can use PET scan as a tool to modulate the risk of further risk stratify the risk of lung cancer for those intermediate risk nodules. And also observing temporal changes is also important, meaning what is a nodule changing in time. I hope you've taken away from the talk today that I think the current, I think it's meant to be solid versus subsolid nodule, but I understand the solid and subsolid nodules are two different beasts, and they're two different entities, and they probably need to be treated and managed differently. But I think the most important message here is, as you can see, this is now a very, very complicated area of medicine with a vast number of algorithms that you need to be able to work out. And I think in reality, your patients are best served by referring these patients to expert centers where there are lots of multidisciplinary team to help you with people that are expert radiologists, people who see a lot of lung cancer with expert in diagnostic procedures, and to work together, multidisciplinary team to get the best diagnosis and management strategy for your patient. So I'll leave off there and hand over to Graham unless there are any pressing questions.
Thank you.
Not a problem. And thanks so much for asking me to be involved with this talk. And thank you, Peter, for a very informative talk. As you can appreciate, this is an area in medicine that really needs specialised people and teams. This is, as Peter mentioned, the management of lung cancer, pulmonary nodules is really in a multidisciplinary setting. Of course, often starts with the general practitioner with an incidental finding, whether they're symptomatic or not, and then with that ongoing referral. But it's really a team approach. And so the surgical management is really off the back of a lot of hard work from everyone prior to the patient actually undergoing the knife. The objectives for my talk, and this is going to be a fairly brief talk. I do realise it is night and you're all probably hungry and wanting to get to your dinner. And this is just a basic overview of thoracic surgery and what we're performing at the moment, and give you some insights as to why we may choose certain operative techniques and procedures, and then a little bit on what's sort of the expected recovery and some common issues that you may see afterwards. In terms of the preoperative consideration, and I'll jump to once the patient is referred to a surgeon, a lot of the staging, of course, is already done. They've had their PET scans, they've undergone EBUS. It's really at that point, on paper, the decision's made for surgical resection, say if we're dealing with lung cancer. And it's really then to see whether the patient can tolerate that procedure, of course. And I think this is really where the art of surgery comes in. Of course, patients' age, their frailty, their generalized exercise tolerance, and we can really look at and define that a little bit closer in terms of stair climb tests. And we often use, can you walk 2 flights of stairs easily before getting significantly short of breath? We can then take that to sort of shuttle walk tests, which are a little bit more involved, to get a good clinical indication as whether this patient's actually going to tolerate surgery. Because with any lung surgery, we're generally taking away some lung volume. So we're taking away functioning lung. And we really need to make sure that that patient will be fine with that lung removed. Of course, comorbidity is really relevant to any procedure, and more relevant to lung surgery, because a significant proportion of these people do have smoking history, they do have other cardiovascular risk factors, and therefore they are at risk of having perioperative infarcts. Also, the patient's pre-existing lung disease and pulmonary fibrosis, of course, and things like strokes and their ability to really rehabilitate after a procedure like this. And of course, you always hear a surgeon say the end of the bed test, and that's where they walk into your rooms and really within about 20 seconds, you get a good idea of whether they're going to tolerate a procedure well or not. Lung function, of course, is an absolutely essential part of our preoperative workup, and this is often done already by the time the patient gets to me. And we're looking at really the FEV1 and the DLCO, so the quality of that lung. And we find that if we calculate after the intended resection what we're going to leave that patient with, and in general, if we're going to leave them with less than 40% of their predicted volume, they are at a high risk of getting short of breath over short distances, but also have higher risks of perioperative morbidity and mortality. So there would be nothing worse than us resecting a stage 1 lung cancer and patting ourselves on the back, and yet the patient can't walk 10 meters. We can also escalate after we've had the clinical assessment, we've done the basic pulmonary function testing. If a patient is a little borderline, and what we often see is a patient clinically is very good, they can walk a couple of flights of stairs, they don't feel short of breath up inclines, and yet their spirometry is fairly average, we can then look at a little bit more involved testing, and that's really the cardiopulmonary exercise testing, where we get a VO2 max. And really, if we know that we're above 10 mils per kilo per minute, then we should be safe moving forward. If it's under that, then really no thoracic surgeon is going to proceed. And this all becomes relevant because each lobe of the lung represents different segments, and we can look at predicting the post-operative lung function, if you like, by the anatomy. So if we're removing say a right upper lobe, we're removing 3 segments. So we can just do, simple percentage mathematics and find out what their starting FEV1, how many segments we're going to remove, and with simple maths, predict what their post-operative values will be. Now, that's a very, very basic way of moving forward, because each segment of the lung, whether it's towards the top, middle, or bottom, will always function differently. And so we can look at from an anatomical point of view. If we've really got a borderline patient, then we can look at sort of further perfusion studies and VQ matching to give this a little bit more science than just a pure anatomical point of view. And this is just a slide actually done by one of the, I believe, the fellows out of Westmead Hospital. And it's a really nice table looking at risk stratification for surgical patients. And once again, we're looking at if the percentage predicted values are greater than 60%, then they really should be completely fine for undergoing any major lung resection. If they're less than 30, then we really need to look at alternative treatments, such as a potential systemic therapy, or becoming a lot more popular now, particularly in patients who cannot undergo surgery, is focused radiation, or SBRT. Once again, we look at that cardiopulmonary exercise testing for those borderline patients. In terms of the approaches to lung resection, really video-assisted thoracic surgery, or the more minimally invasive approaches to lung, is really taking over as the standard of care. There's currently a few large randomized control trials that are in progress looking at the difference between VATS surgery and that of a traditional thoracotomy operation in the setting of lung cancer, to really define that. But there's so much evidence to suggest that more minimally invasive approaches are better for the patient, giving really the same oncological outcomes, which is extremely important, of course, and patients recover better. And it makes sense. If you're not retracting the chest wall in a huge way. You're making smaller incisions. There's less surgical trauma. Patients generally get their pain levels are better. They still get pain. There's no doubt about that. You're still invading the chest wall, but overall the pain levels are much better, and they're able to get up and get going. And in this is a very typical VAT setup where you've got a camera port. You've got here a soft tissue retractor with a working port, and looking over here, this is a very typical setup at Westmead Private Hospital, where the camera technology now is really incredible. We're using 3D imaging now for hilar dissection, which really gives that depth perception, getting around lymph nodes, and making the procedure so much more efficient and safer for the patient. As I said, the thoracotomy, which no doubt you've all seen, and we still have to perform this. There's no doubt about it. This is, I would say, probably represents less than 10%, probably around 5% of the lung resections that I do. We have to do via thoracotomy because they're very large tumours, the position of the tumour. But as you can appreciate, there's a big retractor involved. You're working in a big wound, and that takes its toll on the patient. There's no doubt about it. And our pain management for these patients is significantly different. In terms of the type of resections, we can look at just doing a localized or non-anatomical resection, otherwise known as a wedge resection. I'll show you some detail of that in a second. A lobectomy, and this is an anatomical resection where we're really looking at taking the anatomical lobe. So we're taking the individual pulmonary artery and venous vessels with the draining lymph nodes. And of course, a pneumonectomy, which really now we're trying to avoid if we can, but sometimes it's essential. If we've got a large central tumor where that airway needs to go, then we may need to take the entire lung. Once again, all these procedures in terms of the wedge resection, the segmental resection, so we're taking individual segments from a lobe, lobectomy, and once again, pneumonectomy. And most of these procedures can be done all via a more minimally invasive approach. We've sort of discussed over this the differences between open and VAT surgery, and we'll go through this in a little bit more detail. In terms of positioning, there's usually one larger utility port because at the end of the day, we can do all the dissection and see everything through small incisions that are usually around 12 mil, but we have to retrieve the lung, and we can't get that out of a 1 centimeter hole. So we have to make that usually one utility incision just under the axilla, slightly larger. Once again, the instrumentation is fairly basic for laparoscopic or thoracoscopic surgery. It's because the chest wall is rigid, so it holds the chest wall up. We can use stapling devices now, which have really revolutionized lung dissection and resection. In this case, this is just once again a representation of a single tumor. In terms of wedge resection, this is usually metastatic or oligometastatic disease. For an example, someone that's had bowel cancer, they've had a single met after quite definitive treatment. And in that setting, we know that there's really no benefit in removing the whole lobe. We can just concentrate on that tumor, giving around a 2 centimeter margin either side. So this is a non-anatomical resection, and utilizing stapling devices which seal the lung, which is extremely important in lung surgery because if that doesn't seal well, we get an air leak, and then we can just retrieve that nodule. Now, of course, you can see this is literally a wedge. We're leaving the majority of that upper lobe intact, as opposed to a lobectomy where there's a lot of dissection involved. So you're actually dissecting down into the hilum. You're then looking at individual dissection of pulmonary artery and venous branches. And once again, the staple technology over the last 10 years have been incredible in terms of being able to staple this rather than cut and sew type techniques. And that really has led to patients having less bleeding, less air leak after an operation, which we'll go through later, but often keeps the patient in hospital and can keep them in for weeks if we've got an ongoing air leak. Once again, we take the individual venous pulmonary artery branches and then the actual airway, the bronchus. So we have a lot of recommendations from European societies and also North American societies. And really for the treatment of stage 1 and 2 non-small cell who are surgical candidates, the recommendation is still either open thoracotomy or VATS access can be carried out. The important thing is if you're looking at minimally invasive surgery, you really need a center that has expertise in the surgery. So there's no point a surgeon that does open thoracotomy and has done forever trying to do a VATS procedure. They should do a thoracotomy because they're going to get the best cancer result for that patient. The recommendation is also that VATS should be the approach of choice for stage 1 tumours. Once again, a consensus statement for the International Society of Minimally Invasive Cardiothoracic Surgery. Really with the amount of evidence, VATS is recommended because it reduces the overall post-operative complication rate, reduce pain levels, gets people up and going quicker, and really importantly, because these patients recover, they get up and get going, they're able to tolerate adjuvant chemotherapy if required. As I mentioned before, from an oncological point of view, there's really no difference between the 5-year survival between those patients undergoing thoracotomy and lobectomy. Once again, we're just stating here that in general, less hospital stay, someone undergoing VATS, less blood loss, less complications. A lot of that hospital stay is for analgesia for the patients in thoracotomy, but also air leak. When you're doing an open thoracic procedure, you're doing a lot of dissection of lung tissue, and if that tissue gets disrupted, then it leaks air, and we have to leave that drain in until that basically that air seals over.
I just have a question, Graham. Any lymph nodes need to be removed at the same time?
100%. It's essential that when we're doing any form of anatomical resection, so that be a lobectomy, pneumonectomy, or segmentectomy for primary lung cancer, it's essential that we take the draining lymph nodes. The current recommendations is that we really need to at least sample one nodal group from 3 mediastinal stations. So Dr. Wu had a really nice diagram depicting the different stations within the mediastinum. According to what lobe we're taking, we really need to at least sample those nodes, if not do a full nodal dissection. So 100%, yeah. In terms of robotic surgery, it's essentially using the robot. It's doing essentially the same thing as videoscopic surgery. It's minimally invasive. Often with a robot, we're actually making more punches to the chest wall. So for a standard VATS procedure, we would do about 3 incisions. For a robot, you'd be doing at least 4. So I think there's definitely benefit there. There's benefits in sort of anterior mediastinal surgery. At Westmead Private, we've just got the newest Da Vinci robot, which will be starting thoracic surgery very soon in selected patients. In terms of post-op considerations for thoracic surgery, pain management is essential. For inpatients directly post-op, we place paravertebral nerve blocks. They have a patient-controlled analgesia. Nearly every patient is on some form of opioid, being slow release and then having an immediate release breakthrough. And of course, basic analgesia. So everyone's on paracetamol. And if there's no contraindication, a non-steroidal early on. As an outpatient, most patients after a videoscopic surgery don't require the sustained release opioid, but I always give them immediate release because they may feel fantastic, they get out and then they overdo something and they tweak their chest wall or otherwise. And it's really important that their analgesia is optimized, because if it's not, they're splinting and they're not breathing up, they're prone to atelectasis and postoperative pneumonia. Most of the acute surgical pain really settles after around 2 weeks, although we do see, and I'm sure you've all seen patients after any thoracic procedure that have ongoing pain weeks or even months after the procedure. That's generally due to an intercostal injury, intercostal nerve neuralgia, which we can look at potentially Lyrica. I try not to use it if patients are otherwise well, but if their sleep's disturbed because of pain or otherwise, then we can certainly trial that with sometimes very good effect. In terms of wounds after VATS surgery, quite small. The main issue I see with VATS wounds is one of the most anterior, smaller wound, or the camera port access site we use for the drain, and we often put a purse string in, particularly in patients who have had a prolonged air leak. So that drain has stayed in anywhere from 3 days to up to a week, sometimes even more. That will start to granulate around that drain. So naturally, as they go home and when they're followed up, particularly in your practice, you'll probably see this wound to be open. It can be often raw, sometimes oozing, and it's often treated as a superficial wound infection where it's actually just started to granulate and heal out. In terms of shortness of breath, generally speaking, most patients in that recovery phase, and I say usually that first 2 to 6 weeks, they're not really doing too much to get that shortness, to really feel short of breath. And if they're feeling short of breath at rest, there's a problem. That problem may be they've developed a reactional pleural effusion, whether they've developed a late pneumothorax, which is rare but does happen, or they're developing a post-resection space infection such as empyema. And the easiest thing to do, of course, is a chest X-ray. No one really should be hypoxic after lung resection. So if you see someone at follow-up and they're hypoxic, there's something wrong. And they really need to escalate to imaging and then either hospital admission. And if there's any issue with any of my thoracic patients, I really like just getting a phone call, and I'm more than happy to receive those phone calls in terms of getting those patients the best care, because often it can be just small little things. If they have a reactional effusion, that can be done as a day case through some of our imaging facilities where they come in and do it under image guidance. It's so much better for the patient. They get up and get going. These are just a few images of post-resection normal x-rays. A right upper lobectomy here. You can see the x-ray overall can look fairly normal. This has got a big tube in it because it's day one. But in the correct patient, you don't appreciate too much. Usually at follow-up, in this case here, they've had a right upper lobectomy. You see the hemidiaphragm come up a little bit. There's no blunting of that costophrenic angle, so there's really no effusion or very minimal effusion. You see a little bit of volume loss there, and the mediastinum just edging towards the right. And that's a really good post-operative X-ray. We want all those things to occur so that the inflated lung is taking that whole thoracic cavity. The last thing we want to see is a restricted lung, because if we see a restricted lung, that open space fills with fluid. If that fills with fluid, it can potentially become infected. Of course, this one here, we've done a left upper lobectomy. We can see a bit of pleural tenting, so almost that triangular shape at the bottom. That once again indicates that that lung is filling the space. The mediastinums come over, the diaphragms come up. Generally, I'd expect people after videoscopic surgery to be able to really get up and about by around 2 weeks post-procedure. Of course, everyone's different. You can appreciate all your patients are different in terms of pain threshold and functionality. From a surgical point of view, we generally see them at around 6 weeks post-resection with a chest X-ray. Of course, early, if there's any indication or any issue, there's always follow-up with the referring respiratory physician. And all of these patients are generally presented at our lung cancer multidisciplinary meeting to see if there is any indication for adjuvant treatment. And just to ensure that multidisciplinary approach continues for each patient. That's it for me. So thanks very much for listening and having me today. I'm more than happy to answer any questions.
Yeah, got a couple of questions here for you, Graham. What are the main advantages with robotic surgery?
Yeah, the main advantage in robotic surgery in the world of thoracic surgery is really the anterior mediastinum. So if we're looking at doing a resection for a non-invasive thymoma, that's really where the robot comes into its own because of the dexterity of the hands. The dissection and camera angles can be a lot better in terms of accessing that part of the mediastinum. In terms of lung resection, there's a big debate whether the robot's any better than VATS, and really there's no study to show that it is advantageous. It may be a little bit easier for lymph node dissection, things like that. There are a lot of problems with robotic surgery. You could see in that last picture that the surgeons actually had a console. They're not even scrubbed in. So if you tear a pulmonary artery vessel or something else, you're going to have, you know, half the cardiac index flying out at you, and you're at a console. That's not good. It's not good in any setting. Don't get me wrong, but so overall, I don't think there's many advantages, but in the right setting and for the right patient, can be advantageous.
Okay, excellent. I just have one more question. I'm just scrolling down. And apologies if you've already answered it. If solid nodules is adenocarcinoma without any letters,
Yep.
Why not for lobectomy?
Absolutely. If they're a surgical candidate and they've been staged appropriately, so there's no evidence of mediastinal nodal involvement, it's a well localized tumor in someone that can tolerate lobectomy and they've got good lung function, then they would be at stage 1, and that would be the recommendation, certainly. Yep.
Okay, so it would be good if Graham can be unmuted too. I think it would be good for me to address some of these questions, Graham, to show people how the multidisciplinary nature of these things work. So this is the 60, these are all real life cases. So in April this year, I saw a 60-year-old Chinese gentleman. He originated exertional dyspnea associated with ST depression on the ECG and hence was sent to see a cardiologist who did CT angiogram in August 2019 and that showed minor coronary artery disease and tricuspid regurgitation. Since then, they found a lung nodule of 10 times 9 times 8 mm right lower lobe. He unfortunately returned to China in 2019 and had another CT scan done and saw a doctor there. And this is a very familiar story that we hear. I don't know about others, but I hear this regularly. There was no family history of lung cancer, and he had a 10 package of smoking. And he wasn't a great believer of Western medicine, and actually was used to be in charge of traditional Chinese medicine hospital in China. So let's take a poll. What do you think the next best management step is? So I can read it out, or you can just read it and elect an answer. So repeat the 1 mm CT scan now, and refer to a respiratory physician with links to lung cancer multidisciplinary team, or to repeat the scan in 3 months, organize a PET scan, organize a CT guided biopsy, or refer to a thoracic surgeon for resection of pulmonary nodule, because you're so impressed with Dr. Meredith's talk.
All right, so good to see. Thanks, GPs, for giving that a go. So there's a couple that are clicking. Can you see those results, Peter, as they come in?
Yes, I can.
Great, excellent. Well, you'll be able to talk on them then. Just give them a few seconds. So, so we have a mixed response there, don't we, Peter?
Yeah, so we have a wide spectrum of responses here. 57% of people chose number 1 to send to a respiratory physician, and it's good to know that. Well, actually, it's dropping as we speak to 53%. But it's good to know that you know, people still value the respiratory physician. So I think in these, this is a very tricky scenario, and I think you could probably commonly encounter this situation. So so in terms of the correct answer, of course, I don't think there's a correct answer to this question. What would you do, Graham, just out of interest?
Yeah, I'd probably repeat the 1 mm slice CT and refer.
Yeah, so look, I think, you know, there is I think there is no right answer in this question. I think it is appropriate. I think the best thing is to repeat a 1 mm CT scan to carefully assess the nodule. As we've discussed, the CT scan now is about 6 months old, and you don't know what's happening in the interim, or 8 months old. You don't know what's happening in the interim 8 months. So I think that's probably the most important step here, and that's probably why that's the best answer. At 10 millimeters, I think the risk of this lesion being lung cancer is probably up to 15%. While following it is appropriate to see growth, I think your pre-test probably here is probably a moderate for a lung cancer, and I think, you know, if it was a low risk probability lesion, I'd probably follow. But it's now at moderate risk, and I probably want further risk stratification. I think a PET scan is appropriate to risk assess, and that will be also correct. But I guess if the repeat CT scan show this as 2 centimeters, your decision for this measure is made because you know this thing is growing and it needs further intervention. Organising CT guided biopsy, I think it's dependent on the lesion. Sometimes they are accessible, sometimes they're not. And I guess my warning is that if you haven't had a proper assessment before CT guided biopsy, you potentially may be exposing someone with underlying lung disease to a pneumothorax or bleeding, and which we need to adequately assess prior whether they can actually tolerate this. I think the 5th question is probably also just as appropriate. It's probably not an unreasonable thing to refer to a thoracic surgeon for assessment, providing once more the thoracic surgeon has plenty of experience of managing lung cancer and is involved in lung cancer multidisciplinary team.
I agree with you, Peter, too. And the thing is, I think that's the important thing, that you know, we often receive primary referrals for lung lesions as surgeons. But the great thing about that is, you know, we're part of the multidisciplinary meeting. So if they're potentially not surgical candidates or they've not had the right workup, we can facilitate that very easily. So, you know, in terms of referring to a thoracic surgeon, that's absolutely fine. You know, we won't resect it unless it's required.
Thank you, Graham. So this is the next picture. This is what the repeat CT looks like. So in essence, the lesion hasn't changed a lot. You got any comments on this lesion, Graham? What's your thoughts?
Yeah, in terms of, it's fairly deep-seated within the lung. It's fairly small. It's a solid lesion. From my screen, it looks a little bit irregular, spiculated. You know, it certainly looks suspicious from my point of view.
Yeah, I agree. I think the size is starting to make you suspicious. The speculation is one of those factors we spoke about that has some risk of being a malignancy. So I think once more, this is at least a moderate risk, a probability of being a cancer. So you've referred, as 54% of you have, to see a respiratory physician urgently. What do we think is the next best step here of management? Arrange a pulmonary function test, organise a PET CT scan, organise a CT guided biopsy, arrange for radial endobronchial ultrasound to be performed, or refer for the thoracic surgeon for resection of the pulmonary nodule.
So we've just launched the poll. Questions are coming through. Once again, we have a mixed range of questions here, or answers, sorry.
Okay, so I'm going to start speaking. I mean, I would be interested in your view, Graham. What's your thoughts will be? What would be your next step here?
Yeah, and I think, as you said before, there's no absolute perfect answer here. I'd be really looking at either the pulmonary function testing or the PET CT. Reason being, in terms of the PET, it's going to give us some information as to whether it's PET avid, and then potentially, if it is lung cancer, whether there's any mediastinal or extrathoracic disease, which of course is essential in staging. If we do have a PET positive nodule, we really need to know what their pulmonary function is, because that's going to allow us to know, you know, whether they're a surgical candidate, whether they could even potentially undergo a percutaneous biopsy if that was relevant down the track. So, you know, whatever order those two came in, I think, you know, it's hard to say one over the other. That it'll probably happen simultaneously.
Yeah, so look, I think just to go over some of the answers, I think there's a wide distribution of answers. And I think that's probably meaning that I wrote a good question that's fairly controversial. So I think firstly, the radial endobronchial ultrasound's probably not a good test here. I didn't see enough showing other scans, but there's no airways leading to it. It's less than 2 centimeters. So the diagnostic sensitivity of this test in this particular scenario is low. So that will be the least of my preferences. I guess I think referring to resection for thoracic surgery is always is an option. But I think, as Graham has alluded to, I think this patient needs further staging and workup before proceeding to that. And remember that if this lesion has a 15% chance of being a lung cancer. If we just go straight to resection without any further workup, there may be an 85% chance this lesion is actually not a lung cancer, and we've exposed the patient to a major operation for non-malignant cause. A CT guided biopsy, I think, can be a correct option in the correct patient. And I think in general, I think establishing the tissue diagnosis would be preferable prior to PET scan. However, in this case, it's a fairly deep-seated lesion. You'd be concerned about complication, the ability of the patient to tolerate the complication. So you want to assess a pulmonary function before the CT guided biopsy so that you know if you get a pneumothorax or bleeding, the patient will be able to survive the event. So I think to me, the PET scan is probably the best answer here because if the PET is fairly low in avidity, you may choose to follow this scan, this lesion. If it's high in avidity, it may force your hand into biopsy or undertake further intervention. So I agree with the vast majority of your audience that I think this is the next best answer. So the outcome here is was that the PET scan was done. There was show FDG avidity of 4.3 in the right lobe nodule and some symmetrical uptake in the mediastinum. And the patient had a fairly normal lung function. And I spoke to an expert radiologist who thought this was able to be sampled without risk of complication. And this actually turned out to be adenocarcinoma on biopsy. The patient was then referred to a rhalolobectomy and a lymph node dissection. And on the dissection, unfortunately, it was found to have subcarinal lymph node involvement with the tumor, and hence was upstaged from a stage 1A to a stage 3A due to the lymph node involvement. So I think this sort of answers the question that someone in the audience asked Graham about, does all lymph node needs to be removed? Absolutely, yes. And you know, the prognosis of lung cancer is largely determined by their nodal status. So it's usually how much nodal involved, how far has it spread in the mediastinum that the prognosis is determined by, and hence the importance of surgery of determining the mediastinal staging status. And as you'll note that in the PET scan, the station 7 lymph node did actually not have any uptake. So in fact, in patient with normal CT scan, with normal PET scan, up to about 9% of patients can still have nodal disease in the mediastinum. And hence there are a select group of patients that needs to have preoperative mediastinal staging with endobronchial ultrasound or mediastinoscopy or combination of the strategies. And I think this is the importance of the multidisciplinary discussion. And the patient referred to adjuvant chemotherapy because they had nodal involvement of disease, followed by irradiation of mediastinum in case there were other lymph nodes that were not involved in the mediastinum that had microdeposited tumor. Any questions or comments on Graham while the audience is thinking about questions?
No, I think that's. I think just to go over the importance of the lymph nodes with the dissection, and we often harp on about this, how important that is, because if this patient just had, say, very limited lymph node dissection or sampling, or had no lymph node dissection sampling, you know, this would be missed, and the patient would miss out on that adjuvant chemotherapy, and we'd all be thinking they're cured of cancer when in fact they're not. There was a recent North American study or survey done within the last couple of years that showed, at least in North America, that around 50% of lobectomies that were performed had no attempt at lymph node dissection, and I think that's really disappointing. That is hopefully not the case within Australia, but it just reflects the importance of really that, you know, specialist care and people that specialise in lung cancer management.
Any questions there from the audience, Sandra?
No, no questions come through.
Okay. Do we want to do one more case? There's only one more question.
Yeah, look, I think crack on. We've still got 60 people logged on, so they're still keen. So we'll just keep cracking on. If they need to rush off and do something, you can drop off at any time.
Okay, so this is another case I encountered this year. This is a 66-year-old Chinese gentleman. He was essentially asymptomatic. He had a CT scan done in China in October 2019, and he was told that there was a lingular ground glass lesion. He was otherwise reasonably well, hypertension, reflux, and a patch repair for ASD, and there was no family history of lung cancer. So as we learned today, the first thing to do with these ground glass lesions, repeat a CT scan at 3 months at 1 millimeter thickness, which I did. As you'll probably see from me, if your radiology place is not giving you about 300-400 slices, they're probably not doing. They probably haven't got the 1 millimeter slices, so there should be about 300-400 slices. So this is a CT scan. Graham, do you want to describe this lesion for the audience? What's your thoughts about this lesion?
Yeah, sorry, my screen's just shrunk a bit, but it looks fairly peripherally located on that lateral aspect of the lingular segment there. It's got that sort of hazy areas around it, but it does look like there is some central, more a solid component to the lesion.
Agree. I think this would be classified as subsolid lesions, measuring about 10 by 6 millimeters. And I agree with Graham that there's probably almost like a 5 millimeter solid area in here. And as we know, a size of more than 10 millimeters and the solid area more than 5 millimeters, probably it will increase the risk of it being an invasive adenocarcinoma. So what is the next best step for management of this subsolid nodule? We can start the poll. So refer to a respiratory physician with links to the lung cancer multidisciplinary team. Repeat the CT scan in 12 months' time. Organise a PET CT scan. Organise a CT guided biopsy. Referral to a thoracic surgeon for resection of pulmonary nodule.
All right, once again, a cross-section of responses. So I'll hand back over to you, Peter, to respond. Sure.
So Graham, do you have any comments?
Yeah, I think once again you've done a great job with these questions because a lot of them are relevant. In terms of best answer, I'd probably link this person early. The lesion's got high risk features for malignancy, and I think the easiest thing to do is to refer earlier to a respiratory physician with expertise in the area. And then the PET scan and the tissue diagnosis can follow on. But I think the sooner this patient sees someone with those expertise is probably the best. In terms of PET scan, I think that's extremely relevant. I think the CT guided biopsy may become relevant after that.
Yeah, so if we look at this as a subsolid nodule, I think the literature will suggest there's probably limited utility of a PET scan, and often these lesions may be negative as well. I don't think that should dissuade us from thinking this is a invasive adenocarcinoma, even if the PET scan is negative. So I think, on odd occasion, we do see the solid component have a little bit more uptake, but in general, PET scan probably has very limited value in subsolid lesion. Organising a CT guided biopsy is not an incorrect option here. It's peripheral, it's probably fairly easy to access. But there's a high rate of false negativity rates with these subsolid lesions on biopsy. And so if it's easily biopsyable, it is possible to do. In this particular case, the patient actually went for attempted CT guided biopsy, but when the patient was put in position, they had difficulty locating the nodule due to collapse of the lingula in that particular position, so it couldn't be performed. I guess the alternate option here would be to the next option would really be if we think there's a high pretest probability of being a lung cancer, you then refer to thoracic surgery for resection of the lesion. And I think that's actually a very reasonable option. I think the patient needs to be counselled appropriately because based on what we've learned tonight, there's probably statistically about an 80% chances of lung cancer. But you do then need to counsel the patient appropriately that there may be 20% chance that they're undertaking resection for a non-malignant lesion, and the patient not prepared to accept that, then probably a repeat CT scan in 12 months is not an unreasonable option either. But I think I agree. I think the referral to a respiratory physician with experience in managing these complex subsolid nodules with links to lung cancer, MDT, and who understands how to counsel the patients appropriately with these statistics is quite important. So this patient, I didn't have a follow-up, but went on to have a wedge resection and was confirmed to have an adenocarcinoma. So I might just finish off there.
We hope you have enjoyed this GP education program with Dr. Peter Wu and Dr. Graham Meredith. To gain your CPD points, please complete our evaluation using the QR code on the following page or the SurveyMonkey link provided. We hope you can join us for more of our GP education in the coming weeks. Thank you.